Thank you very much. Great, my slides seem to be up. I can see them on the screen here. I'm not sure if. Great, thank you. Eric Secemsky, I'm an interventional cardiologist, vascular interventionalist at Beth Israel in Boston. And I was charged for the CFA session, which is our current session, talking about Supera stenting and an update on a prospective study of Supera stenting in the CFA. These are my disclosures. So, and for all the vascular surgeons in the room, I ask you to put some earmuffs on because we always talk about common femoral endarterectomy as the gold standard. And that's because we've had some really good long-term outcomes reported over 5 to 15 years. And you can see a summary of some of the landmark studies. These are over a decade old now, but most of these are single center collection of patients, 158, 111 patients who also great patency rates over the long term. But it's not all positive. And we also know there's a dark side to any type of invasive procedure, but also surgical procedure. And so on the dark side of common femoral endarterectomies, the complication rates, which can be anywhere between 6.6% and in some sites up to 17%. And obviously there's a lot of surgical dependence here, operator dependence, and local practice patterns. But this was a nice study that came out in 2015 that looked at 1,843 common femoral endarterectomies. And they had a reported 30-day mortality rate of 3.4%. And then again, we see the range was a little bit lower in prior studies and 15% combined mortality and major complication rate. So, I think that although the efficacy is proven and durable, that we do have to be mindful of those patients who are at high risk for complications, and that these are not always benign procedures. So, there's been a number of attempts to demonstrate the endovascular approach for common femoral artery stenosis. And here is a study out of the VQI, the Vascular Quality Initiative. And I looked at all their common femoral and profunda interventions from 2010 to 2015, totaling over 1,000 peripheral vascular interventions. Again, this is a surgical database. And the majority of the interventions were a balloon angioplasty alone, and this is before drug-coated balloons were really on the market. But about a quarter of them got stents, and you can see about 1 in 5 got an atherectomy. And at 1 year, the survival rate was good, 92.9%. The amputation-free survival rate was very good, 93.5%. But there was some moderate patency and reintervention rates in the mid-80s. And so the conclusion for the study was safe to do an endovascular approach for common femoral, but there also is patency that's different than you would see, which is a surgical approach. We also saw not too long ago the TECCO Trial, which was a unique randomized trial, which we don't get a lot of in the peripheral vascular space, that looked at common femoral endarterectomy versus a self-expanding stent. And I'm going to talk a little bit about why maybe this wasn't the right treatment arm from the endovascular standpoint. But this was a 17-center study, and they had kind of a odd primary outcome, which was primarily a mortality and morbidity complications, which obviously would favor an endovascular approach at 30 days. But I'll just point your attention to the primary outcome occurred in 26% in the common femoral group, 12.5% in the stenting group. And if you look over in panel B on the patency side in my Kaplan-Meier curves here, you can see TLR rates up to 2 years were pretty similar between surgical approach and stenting with the self-expanding stent. Again, there were some important exclusions in this trial, and again, using a self-expandable stent was unique to the design, but just again showed some more randomized data now saying that an endovascular approach for common femoral disease is not unreasonable when we're also considering the complications and risk to our patient. But we also know that maybe these type of stents are complicated, and this whole SFA is really a complex beast in itself. And this is a really nice diagram of the flexion and torsion that occurs with your SFA artery. And it's just dynamic. It depends on how you hold your leg, how you cross your legs, your age, your lesion characteristics. And this is the view of the leg bent. And you can see that the forces on both the distal SFA as well as near the common femoral makes it very challenging to identify what's the right stent choice for each of these lesion locations. And I think that's where uniquely Supera's come into play for this type of intervention. We've heard a little bit about Supera earlier in the morning, but really it's a unique stent design. It's an interwoven nitinol stent, and it maintains as much of the natural behavior and function of the vessel as possible for any of the stents that are on the market. this also allows us to minimize vessel injury and avoid fracture. And so it's a unique opportunity to use the stent in an artery like the common femoral, where we might need to reaccess it, where there might be, again, flexion and extension points that can cause stent fracture, and also unique issues with the inguinal ligament and other components of the region. So the VMI-CFA trial, and these are results from Cohen-Deleuze, who presented these in 2019, was a prospective single-arm study of 100 patients that were followed for 2 years. And really, they were looking at a 12-month endpoint based on ultrasound, a PSVR of less than 2.5, and then also paraprocedural endpoints. And you can see this azima criteria here of the different types of common femoral disease and the inguinal ligament, how it crosses. And so this study focused really on the B and C, so kind of the distal common femoral below the inguinal ligament, and then also disease extending into the profunda. So I'm sorry for the quality of this, but you can see out of the 100 patients randomized, they're primarily male. Their average age was 72, and they had the usual amount of comorbidities you expect for a peripheral vascular study. About 79% were claudicants, 21% CLI, and this circle in the middle demonstrates the breakdown of the RF classifications, 58% being in the RF3. You can see nicely represents our patients, 44 millimeters in length lesions and reference vessel diameter of 7.3. And all 100 patients had technical success with an endovascular intervention in this study. Again, all of this was Supera stents. The majority required only one stent. About 2% received 2 stents. And the average post-dilatory stent size was 7.3 millimeters. So it was a very good result here. And you can see the outcome. So this is the Kaplan-Meier curves at 1 and 2 years. So again, Supera stent, common femoral, 95.2% patency at 1 year, 92.8% patency at 2 years. So quite impressive results. Again, I showed you that early experience where they were more in the 83 to 85% range. This is now approaching what has been reported for common femoral endarterectomy. When you break this down by azima type B and C, you again see that pretty much that patency is preserved irrespective of the location of the common femoral artery disease. This is the TLR and TVR rates also. So now looking at target lesion revascularization in the top left, target vessel revascularization in the bottom right, and target lesion revascularization remained really impressively right around 98%. The target vessel revascularization dipped at the second year down to 84%. And most importantly, there's very, very few complications with this approach. You can see zeros across the board here. Clinical-driven TLR was one of the complication events, and there was 2 events at 1 year and persisted to 2 years. So, my take home from the data is there's no one size fits all for common femoral artery disease. I very frequently refer for endarterectomy. I've also moved more aggressively into an endovascular approach for patients who are particularly high risk, who have comorbidities, and other reasons not to undergo a surgical procedure. I think if you are approaching a common femoral lesion, there are options. Some of them might be drug-coated balloon approach. Some might be stenting. And if you are stenting, I think Supera is the right stent due to its crush resistance, it's repuncturable, and that patency outcome seen in this study was quite impressive. There is the SuperSurge RCT trial that has been ongoing. And this has been it's a randomized trial, 1-to-1 of 286 patients. We haven't heard an update from this for a little bit of time, but I know it's still in process, and I think it'll better answer this question looking at a surgical randomization arm compared to the Supera stent. So I'm going to stop there. Thank you for your attention.